Good morning and welcome to the Virtual Prostate Summit brought to you in partnership with Northwestern University Feinberg School of Medicine. My name is Dr. Leonard Gamella and I'm the Chairman of Urology at Thomas Jefferson University in Philadelphia. And you're currently tuned into a session called Individualizing Therapy for the Prostate Cancer Patient, a Growing Set of Options, with my guest, Dr. Judd Mal. Before I get started, I'd like to remind everyone who has the opportunity to do so to please send in your questions early so we have an opportunity to have an interactive session with you. Throughout the presentation, Dr. Mal and I are talking. You're welcome to send your questions in. I'm pleased to be here with Dr. Judd Mal, who's the director of the Duke Prostate Center and professor of surgery at Duke University School of Medicine. Dr. Mal's clinical interests include minimally invasive nerve-sparing radical prostatectomy, the treatment of PSA-only biochemical recurrence of prostate cancer, the issue of prostate cancer in African Americans, the multidisciplinary approach to prostate cancer, clinical trials in prostate cancer, the management of early-stage testicular cancer, and prostate cancer outcomes and database research. Dr. Mal has done a lot of practice-changing research in this area over the last 20 years, and it's a great pleasure to be here with you today. Dr. Mal, welcome.
Thank you, Dr. Gamel. It's a real pleasure to be here, and we're excited to be broadcasting here from Duke University, and I bring greetings from Duke, and as you see on this slide, greetings from our Duke Cancer Institute and the Duke Prostate Center, and you'll notice on the left-hand side of the screen is the Duke Chapel, and this is a virtual summit, but just it's important for people to know where we are. We're about 50 yards from the chapel, right next door in the studio. So I also bring greetings from the Duke Prostate Center, and you see our marketing advertisement on the right-hand side of the screen. Now, this slide is, I have to give credit where credit is due. Dr. Gamella, I think we've been friends for many years, and I learned from him in his educational talks that it's never a good talk on prostate cancer unless you recognize some of the poster boys. And on this slide we see all the men who have been diagnosed and treated for prostate cancer, and unfortunately some of the men on this slide have passed from prostate cancer with advanced disease. Certainly here in North Carolina, our poster boy is Richard Petty, as you see on the slide, and certainly in our state we refer to him as Sir Richard, and you certainly can't be live here without being a fan of NASCAR. So he's our poster boy for prostate cancer. But I would say the real poster boy we can see in practice is essentially two guys. We're seeing a lot more men who have very low risk prostate cancer. They were diagnosed maybe with 1 or 2 biopsy cores positive, a low PSA. And the dilemma we face as far as individualizing therapy is, should we treat these men aggressively or actively with surgery or radiation, or should we do active surveillance? And so the program today will be discussing that. The opposite extreme are the men who still present with advanced prostate cancer and high-risk features. And before we go on, maybe I could just ask Dr. Gamella, Lenny, do you think that, I know Dr. Catalona spoke this morning about screening. Do you think that the backlash against screening might shift the pendulum towards more advanced disease?
Well, I think there's no question that we can't look at screening in isolation. The whole issue about the controversy of screening really is more about the overtreatment of prostate cancer, and I think that's really where we have to focus our efforts going forward. We really want to identify, as I know we're going to talk about, those men with the high-risk features, because those are the gentlemen who are going to die from prostate cancer. It's unlikely that the men with low-risk disease are going to die, but certainly I think it's important for us to do screening because we want to find the men who have aggressive, life-threatening disease. At the same time, we need to really reset our thinking and realize that many men that we detect with screening cancer through screening can be treated with active surveillance.
And for those listening in who don't maybe do prostate cancer every day, certainly most urologists, radiation oncologists, and medical oncologists are still going to favor screening because we don't want to see the ravages of the disease. It's easier for us to treat men with localized disease. Nevertheless, we are seeing more patients with both advanced and localized disease. Now, the next slide illustrates at the top, you see individualizing therapy in the baby boom era in prostate cancer. And I wanted just to spend a few slides looking at the type of patient that we see today with prostate cancer. Who are these patients who are having to make these individualized treatment decisions? And this slide illustrates the challenge we're all facing in medicine, which is this large population of baby boomers. Huge increase in our population of patients over 65. These are the patients who are going to get prostate cancer and get the diseases that we all face as we get older. And so it's important to really focus on this individualized approach as we're seeing more baby boomers. And again, the boomers expect this. They expect this individualized approach from us. As you see on this next slide, we're talking about a huge increasing population, up to 82 million men who are baby boomers who are going to be turning 65 over the next decade. So these men are at risk for prostate cancer, and so it's really important that we talk about this individualized approach for these baby boomers. The other challenge we face with prostate cancer, yes, it's a disease of older men, but patients are living longer. And this slide illustrates a key concept that if we see an individual with localized prostate cancer at age 60, that gentleman has a median 20-year life expectancy yet. So these guys are going to live a long time, and it really plays into how we make these individualized treatment decisions. Even at age 75, the median life expectancy is still over 10 years. And I'd like to just again ask Dr. Gamella, so, you know, a year or two ago, you and I have talked about this U.S. Preventative Services Task Force basically told our viewers today that we shouldn't even do a PSA test on fellas above 75. And I know, I suspect Dr. Catalona talked about that. Do you have any comment on that?
Well, I think that the first thing is we haven't seen the final report from the United States Preventive Services Task Force, so it's anticipated any day now. The big challenge that we have is that that report, as we spoke about earlier, really focused more on the complications of treatment and really didn't give a fair shake to things such as the fact that when you use PSA-based screening, you identify less men with node-positive disease, you identify less men with metastatic disease. So there are some benefits to PSA screening that the Preventive Services Task Force chose to ignore.
Right.
The other challenge with the task force recommendations is they took things like the European randomized trial on prostate cancer screening and said it only had a moderate benefit,
right,
when in fact most of us would consider to be a 20% reduction in mortality from prostate cancer from screening to be quite significant. So a lot of political spin out there. We're anxiously awaiting to see the final report from the Preventive Services Task Force. But one take-home message we have to be very careful about. In the age of healthcare reform and the Affordable Care Act, if that report comes through with anything less than a B recommendation, the whole issue of doing any PSA screening may not even be covered by insurance carriers. So this is something we're going to have to watch very closely, because in the Affordable Care Act it says only recommendations from the Service Task Force with an A and B recommendation will be funded. Very questionable if a C and D recommendation is going to be able to be paid for by even organizations such as Medicare.
And honestly, I think that would be a disaster, because then we go back to the bad old days when 25% of our patients presented with metastatic disease. But the key teaching point on this slide is that patients are living longer, and really puts the burden on us to really recognize this individualized treatment approach. And many patients have a long life expectancy. The other issue we face is the baby boomers are more educated, and an educated population is a great thing, but education means that these patients have a high bar. They expect education from their physicians and healthcare providers, and when we have a newly diagnosed patient with prostate cancer, we certainly owe it to these patients to educate them in a multidisciplinary fashion so that they have a full understanding of the treatment options and can avail themselves of that. The population is also wealthier. Despite the economic downturn of a few years ago, we are a wealthier society, and wealthier patients also demand more education and more counseling and have a higher bar for success. So that puts pressure on us to do the right thing, which we should do anyway, but to really do a good job with this individualized therapy for these men. We also face a healthcare provider shortage. This is just one example in this slide from ASCO. American Society for Clinical Oncology, just suggesting that we may have a future shortage of oncologists. We also have a shortage of urologists, radiation oncologists, and this puts further pressure on the healthcare system to do this individualized therapy for prostate cancer. It's the right thing to do, but we may have challenges providing that. Now, you see this headline, study emphasizes the value of the annual PSA test. And again, Dr. Gamella and I have been discussing this, and individualized therapy starts with an individualized approach to PSA screening. Despite the controversy surrounding the PSA test, it's important, I think, for men to have an individual discussion with their healthcare provider about the pros and cons of getting that continued PSA testing. This slide illustrates a key concept that I certainly believe in. Dr. Gamella and I are both urologists. We're both members of the American Urological Association, which is our key professional society. And the American Urologic Association, along with the National Comprehensive Cancer Network, recommends that all men have a baseline PSA test at age 40. Not only for screening, but that value at 40 really can help determine that man's future risk of prostate cancer. And I know Dr. Catalona discussed that this morning, but again, that plays into the individualized treatment decision. Having that value at 40 gives men more options later on so they can follow the value and they know better what to do than if they've been diagnosed with prostate cancer because they have that baseline value at 40. Now, you see this slide showing the high road, and certainly when we manage both localized and advanced prostate cancer, we want to take the high road with our patients, trying to educate them honestly and openly about the various individualized treatment options. And I want to spend a few slides on the contemporary treatment of localized prostate cancer and taking an individualized approach. Here's an example, and this was a nice little review article that was in the New England Journal of Medicine a couple years ago, written by Dr. Patrick Walsh and colleagues from Johns Hopkins, which uses an example of a type of patient that Dr. Gamella and I would see virtually every day in clinic, and any urologist listening in or watching this program can relate to this slide. 68-year-old healthy man, PSA was 4, then it was 4.3, and then 4.7 over the last several years, just this gradual rise. He had a normal digital rectal examination, and his transrectal prostate volume was 48 cc's, again indicating some prostate enlargement. And unfortunately, he had low-grade prostate cancer, Gleason 6, in 1 of 12 cores. And so the individualized approach would be, this gentleman is a candidate for active surveillance, radical prostatectomy, and radiotherapy, and various types of radiotherapy, various types of radical prostatectomy, and there's even variations on how individual doctors do active surveillance. Now, what I want to do is just spend a couple of slides on a project that we're very proud of here at Duke. We've had a true multidisciplinary clinic that we run once a week since 2004, and we published our initial results on this in January in the Journal of Urology. Now, I want to give credit where credit is due. Dr. Gamella and his group at Jefferson have done a lot of work in this area as well. Dr. Crawford at Colorado has published recently on multi-D, and I don't have a slide on it, but Dr. Gamella's group showed that patients who went through the multidisciplinary clinic at Jefferson actually had a better survival and better outcomes. In our study, we began this clinic in 2004. This clinic was held once a week, and each patient saw a urologist, a radiation oncologist, and a medical oncologist in the same clinic visit. We also had educators there, research nurses, and other support. And I'm reporting here on the first 701 patients who went through this true multidisciplinary clinic. And what we found in this clinic was about a third, I put a highlight box on, a third of the patients had high-risk prostate cancer. The types of patients who clearly need a multidisciplinary approach involving multiple specialties. You can see on this slide also a large number of patients, about 40-some%, had low-risk prostate cancer and would have been also candidates for a variety of treatments. 58% of the patients who came to our multidisciplinary clinic, and they could have come from throughout the state and throughout the region. About 58% of those patients actually received their treatment at this institution, but 42% came here for the multidisciplinary education and opportunities, but then went back to their local hospital or facility and had treatment there. And what we found is that about half of the patients where they had this full-fledged education chose radical prostatectomy. In fact, 51.7% of these fully educated multidisciplinary patients had radical prostatectomy. About 1/3 had some form of radiotherapy, and just under 10% had active surveillance. And before I move on, I know, again, Dr. Gamella has done a lot of work in this area, and do you want to make any comments about how this compares to your multidisciplinary approach at Jefferson?
Well, as Judd mentioned earlier, we've shared a lot of common interests over the years, and we've shared an interest in the multimodality approach to prostate cancer because we recognize, as Judd pointed out, it's the high-risk patient that really has the biggest challenge when it comes to the survival advantage that a multidisciplinary approach can offer them. So when we went back and we started our clinic in 1996, and we actually have gone ahead and looked at our survival data. And to be fair, when you have low risk or stage T1 or stage T2 prostate cancer, your 10-year survival, even in our multidisciplinary clinic, really approaches 100%. But when you move off into those high-risk patients, as Dr. Mal has pointed out, the gentleman with T3, T4 disease, locally advanced prostate cancer, almost all of those patients end up having high-risk features by the D'Amico criteria. Getting the team together, discussing the case, and bringing in the different treatment options, including clinical trials, we have shown leads to a survival advantage. And I think that while every institution can't do this, I think that certainly the larger academic medical centers and the NCI designated cancer centers are all moving to this model because while it may not be that big a benefit to the patient with a low-risk cancer, it gives the patient with the bad cancer a survival advantage. But one more point about the low-risk patient. Treatment regret is a big problem in prostate cancer, and we believe that by making sure the patient understands all their options from active surveillance through some form of active treatment, including radiation or surgery, that hopefully treatment regret will become less for these individuals if they are seen in this multidisciplinary setting.
It's an excellent point. As Dr. Gamella said, what we found, interestingly, is that the patients who had high-risk prostate cancer were more likely to actually stay at our institution for the treatment. Again, suggesting further that when we were offering more multidisciplinary options and more of an individualized approach to these high-risk prostate cancer, that's what kept them at our institution. Now, when we're dealing with this patient with localized disease, with early-stage prostate cancer, again, we mentioned earlier, this man could be a candidate for radical prostatectomy on the slide, abbreviated as RP, for radiotherapy, or for expectant management. And again, for the listeners, participants, we can call it expectant management. Some people call it active surveillance. Some people even still call it watchful waiting. But it's an active approach where you're monitoring patients for progression before you actually intervene with surgery or radiation. Now, the challenge we face as we have an aging population is that the benefit to these aggressive approaches is more clear when we're dealing with younger men in the 40s, 50s, and early 60s. This review article brings home a sobering point, which is that perhaps in men above age 65, we would have to operate on perhaps 300 men to prevent one prostate cancer death at 10 years. And that brings up the dilemma of the individualized approach, not over-treating some of these men with very low volume, low-grade prostate cancer, but also not under-treating these patients with high-risk disease who clearly need an aggressive approach. What I want to do is show you some data from Duke. What we're looking at on this slide, the yellow curve illustrates what happened with prostate cancer on a national level, moving through the early PSA era, which is in gray, what we call the mid-PSA era, which is in pink, and the more mature PSA era, which is in the very dark color. And the numbers on the slide represent fellas or patients who had a radical prostatectomy at our institution in these 3 distinct time periods after PSA blood testing was introduced into our population. And a little bit of a busy slide, but what I'm trying to illustrate here is the concept of stage migration. And I won't belabor this too much, but in the earliest patients, those patients treated in the early PSA era, about half of those patients had fairly high volume prostate cancer in their prostate. But by the late PSA era, the most mature era, a much higher percentage of those patients had very small amounts of cancer in their prostate. Again, the key concept for the learners today is this concept of stage migration as we've moved through the PSA era, making the individualized treatment approach even more critical than ever. Another key concept is illustrated on this slide, that even with in men who had very small cancers, specifically in the guys who only had about 5% of their prostate cancerous, 5% cancer volume, even in this group of men, 70% of these fellas had bilateral prostate cancer. So many of the listeners would say, well, my goodness, these small cancers, why don't you just treat a part of the prostate as opposed to taking the whole thing out? Well, the challenge is, even with the small ones, most of the time they're spread out on both sides of the prostate. So until we get very accurate imaging of the prostate gland interior structures, it's going to be challenging to do focal therapy on a large percentage of patients. Now, the last section of the talk is on advanced prostate cancer, and we're going to have other sessions today on advanced prostate cancer. So I just want to whet people's appetite to what we're going to be discussing in further sessions. This is a busy slide, but it illustrates the whole variety of medical treatments we have for advanced prostate cancer, starting with various types of hormone therapy. And again, for people listening in who don't do prostate cancer every day, you might hear it referred to as medical hormonal therapy, androgen deprivation therapy, hormonal therapy, and it's basically medications, injections, or pills that lower a man's testosterone level. We know that testosterone is the fertilizer for prostate cancer growth, and hormonal therapy involves lowering the testosterone level by whatever means is necessary. And urologists, medical oncologists, and radiation oncologists who work in this field have grown up with hormone therapy. We use it every day in our practices. There's some new things that we've had in the last year, specifically abiraterone, trade name Zytiga, was FDA approved in April of 2011. As far as chemotherapy, we've had mitoxantrone and Taxotere or docetaxel, and a year or so ago, cabazitaxel or Jevtana was also FDA approved. And then as far as immunotherapy, Sapulus LT was also approved in 2010. Trade name is Provenge, and you'll hear about that later on today. And then bone targeting agents. So again, just to finalize this individualized approach session, a couple of things to specifically mention that are part of the individualized program for patients with advanced prostate cancer. That would be cabazitaxel, trade name Jevtana, Sapulus LT, trade name Provenge, abiraterone acetate, trade name Zytiga, and denosumab, trade name would be Xgeva if it's being used for skeletal-related events prevention, and Prolia in a lower dose if it's used to prevent bone loss in men who are on androgen deprivation therapy. Now, this headline or slide shows a good friend of Dr. Gamella and myself. This is Dr. Oliver Sartor, who's a medical oncologist in New Orleans. And Dr. Sartor was the principal investigator on the pivotal clinical trial resulting in cabazitaxel achieving FDA approval for advanced prostate cancer. You'll hear about this later on, but again, this just shows the survival curve showing that in the post-Taxotere or post-docetaxel setting, that this drug resulted in an improved overall survival and achieved FDA approval in June of 2010 as a rapid approval, because this was a very novel finding at the time. No other agent before this had shown survival after patients had progressed on docetaxel. Now, Sapulacel-T, you see this headline, Sapulacel-T immunotherapy approved for metastatic castrate-resistant prostate cancer. And this is a very specific product for an individual patient. Again, there's going to be a separate session on this later today where listeners, participants can get a detailed discussion of this, but this involves the patient having a leukapheresis to take white cells. Those cells are processed at a facility, and then each individual patient receives his own activated cells. This was a remarkable finding that this immunotherapy, for the first time in immunotherapy, had shown a survival benefit in advanced cancer. So the IMPACT trial was the pivotal trial resulting in Sapulacel-T FDA approval, and it showed a 4.1-month median overall survival in patients with advanced prostate cancer. This now also has national coverage from Medicare, so this novel therapy is available to virtually all of our patients in this country. This headline talks about abiraterone acetate showed increased survival in metastatic castrate-resistant prostate cancer. This is used in a similar space as cabazitaxel, meaning in those patients who have progressed after docetaxel chemotherapy, they now can be treated either with abiraterone acetate, which is an oral agent given with low-dose steroids, or those patients could be treated with cabazitaxel. And certainly both of these agents, cabazitaxel and abiraterone, have really added to our armamentarium for advanced prostate cancer and given us more options and more individualized treatments. And this was FDA approved for post-docetaxel progression April 28, 2011. The final agent I want to mention that's FDA approved is denosumab, which is a rank ligand inhibitor. It's used subcutaneously and given to prevent skeletal-related events in men with advanced prostate cancer. This is somewhat of a busy slide, but for brevity here, it prevents the vicious cycle of bone breakdown in patients with advanced cancer. And the denosumab is a monoclonal antibody that breaks this vicious cycle of bone breakdown. In a comparison, when you look at this particular slide, it looks at placebo. It also looks at zoledronic acid or Zometa, and then it looks at denosumab, which trade name Xgeva, showing the prevention of these skeletal-related events in patients with advanced prostate cancer. So a number of years ago, zoledronic acid was FDA approved. That's a intravenous bisphosphonate that's given by an IV infusion, and that clearly showed a benefit for our patients over placebo. And then last year, denosumab was compared to zoledronic acid and showed further improvement in the time to the first skeletal-related event. So we now have in this individualized treatment approach both zoledronic acid and denosumab to help care for our patients to prevent skeletal-related events. Now, most recently, denosumab, as the generic name of the product, was also FDA approved in a lower dose, which is 60 milligrams subcutaneously twice a year, to prevent further bone loss in men who are receiving androgen deprivation therapy. And that was approved September of 2011, and that trade name of that is Prolia. Before we close and open up to questions, just a couple of other hot things that are in the pipeline. One is radium-223, which is a radiopharmaceutical typically given either at most hospitals it would be given in the nuclear medicine department or perhaps in the radiology department. It's given to further also prevent skeletal-related events and bone pain, But this new agent, which is an alpha-emitting radiopharmaceutical, had the advantage of also improving survival. And because it's an alpha-emitting agent, it did not cause the neutropenia and the bone marrow toxicity that was associated with some of our previous similar agents. Now, this is not FDA approved, but it's important for the listeners to understand that this is in the pipeline and likely will receive FDA approval later this year. And this just shows the survival curve. This is quite interesting because this is the first radiopharmaceutical agent that has been associated with any type of survival benefit in advanced cancer. So it's quite interesting. Then finally, another investigational agent in the pipeline is a drug called MDV-3100. This is an androgen blocking agent. It's an oral agent. And if, as a urologist or an oncologist, you might think of this similar to bicalutamide or flutamide or nalutamide, which we've used for many years orally, except this agent seems to be much more potent and has a more robust mechanism of action. The key teaching point, though, was that in a phase 3 trial, again looking at the post-docetaxel setting, this drug also showed a survival benefit. Interestingly, the patients that received MDV-3100 had a median survival of 18.4 months versus 13.6 months with placebo. So again, the key teaching point is, although this drug is not yet FDA approved, in our individualized management of patients with advanced prostate cancer, we soon will likely have 3 agents in our toolbox for the post-Taxotere setting. We have Jevtana, which is cabazitaxel, which I mentioned earlier. We have abiraterone acetate, or Zytiga, which is FDA approved, and we probably will have MDV-3100 in this setting. So potentially 3 agents. And we'll start to use these agents in earlier settings as those trials are completed. So my last formal slide, I tried to convey that there's clearly a growing population of men at risk for prostate cancer, this baby boom generation that certainly I'm part of that generation as well. And I think Dr. Gamella and I are both baby boomers. We represent this huge population of patients who are, more and more of us are turning 65 or over 60 every year, and a lot of patients at risk for prostate cancer. We tried to talk a little bit about the screening debate. Again, I know Dr. Catalona covered that beautifully this morning, but again, it remains controversial. The continuing trend to low-risk disease, we need to take a better individualized approach in managing these low-risk patients, offering them the full education necessary to make a decision between active treatment and active surveillance, multiple treatment options for localized disease. We just touched on surgery and radiation, but Dr. Gamella and I would be happy to take questions about surgery and radiation during our panel. We talked about the multi-D approach, and then we whet your appetite for some of the newer agents in advanced prostate cancer, Sapulacel-T, cabazitaxel, abiraterone, denosumab, and other agents in the pipeline. It's a really exciting time to be working in the field of prostate cancer because we have more options for our patients, and it gives us a better opportunity to apply the individualized treatment approach. So with that, thank you very much. I've really enjoyed the opportunity to be here, and for Platform Q for giving us this opportunity to be part of this program. Thank you.
So what I'd like to do is remind everyone who's on our online audience right now to please send your questions in. We already have a few questions that are coming in, and I'll be asking Judd to comment on some of those in a couple of minutes. But one of the points, Judd, that you made, I think your overall snapshot of certainly what's going on with prostate cancer is outstanding. One of the interesting things that you point out is that we're going to be having more and more options for patients. So would you comment a little bit on the double-edged sword? The more treatments we have for prostate cancer, the more confusing it becomes for an individual patient. So when you're presented with all of these new options for castrate-refractory prostate cancer in your multidisciplinary clinic, How do you guys sort out standard of care? I assume, and I know your work that you've done these years, you try to get everyone on a clinical trial,
right?
And that is the that's the state of the art for cancer care today. But what about all these new competing options for castrate refractory prostate cancer? For example, does Duke offer Sipuleucel T? Do you have that set up here on the at the Duke Cancer Center? What about the medical oncologists, and do you prescribe any abiraterone, or do you let the medical oncologist prescribe that? How do you handle all of these new agents for advanced prostate cancer in your multidisciplinary setting?
So you start off with a really tough question. I mean, that's the good news, bad news. We have a variety of treatments. The bad news is, how do we sequence them properly to get the best benefit for each individual patient? Couple key points. As we have more agents, it's more critical for urologists and medical oncologists to work together, and we're very blessed here that we work as a team. The urologists have most of the patients who are in the phase of PSA-only castrate-resistant disease, or those early bone mets patients. So one of the messages to the urologists who are part of this program today is, you have to have your radar up to think about getting imaging a little bit more often, trying to think about getting a bone scan. If that patient has a rapid rise in their PSA while they're on LHRH therapy, really be thinking about the possibility of metastasis. For example, so we use Sipuleucel T, and in fact, as of a couple months ago, I think our institution was number 2 or 3 in the country as far as Sipuleucel T infusions, and very active program. Remember, for the listeners, Sipuleucel T is for patients who are asymptomatic or minimally symptomatic, essentially with bone. They have to have bone metastasis, but they also have to be asymptomatic or minimally symptomatic. So it's important to monitor these patients and not miss your opportunity on that therapy if you're trying to do the best for your patient and offering a this multimodality sequenced approach. Once the patient then has been through the Sipuleucel T, if they have at some point when they progress and become symptomatic, usually the next step in the progression would be docetaxel, which has been our go-to FDA-approved chemotherapy since 2004, and off clinical trial, most patients would go with Taxotere. Ideally, you would love to have that patient be able to make it through at least 10 cycles of Taxotere, which would be a full cycle or a full course, and then some patients could even be retreated if they're good responders. The question then, as after the patient progresses on docetaxel, does our team go to abiraterone first or Jevtana? And it's an individualized decision. There are some patients who are in the chemotherapy mindset. They have gotten through that. They haven't had too many problems, and they may choose to go directly from docetaxel to cabazitaxel. Other patients may want a drug holiday from chemotherapy, and they may choose to go on abiraterone before they go on to Jevtana. Another issue is prior ketoconazole use. That some patients, if they had prior ketoconazole prior to docetaxel or after docetaxel, they still may respond to abiraterone, but they may not have quite as robust a response to abiraterone. So again, I don't want to take too much time on the question, but it's bottom line is we work as a team. But again, I'm a urologist, but I really take a pride in, and I really want to have a working knowledge of advanced prostate cancer too, and be an active participant in the team.
And I think you make, Judd, a very good point that urologists traditionally pass things off to the medical oncologist, but understanding that important interaction between the surgeon, the radiation oncologist, and the medical oncologist, and deciding, okay, when is it appropriate to send someone to that next level of treatment is becoming more and more complicated. We just had docetaxel approved in 2004, and now, as you pointed out, the last 2 or 3 years we have had 3 new agents, and in the next year there's likely to be a couple of more, as you nicely pointed out. So let's take some questions now from our participants who are online right now. One of the questions comes in is that if you're counseling a medical professional in your clinic on active surveillance who appears to be the standard low-risk patient in the range of, let's say, age range of 55 to 60, would you be comfortable offering active surveillance to this man in the absence of having a complete stereotactic needle biopsy of the entire prostate, essentially mapping the whole prostate as opposed to our standard 12-core biopsy. You know, there's many individuals in the United States, Dr. Crawford, who's participating today, who are advocates of this very detailed mapping of the prostate. Do you incorporate this detailed mapping in your active surveillance, or do you rely primarily on the standard 10 to 12-core biopsy?
That's a great question, and in fact, I'd be interested in to hear your comments too. The bottom line answer is we take an individualized approach. Now, this particular patient is a young man. He's 55 to 60. We're assuming he has no comorbidities. So for the listeners, that's the guy who we're more worried about active surveillance, mainly because he has a lot more to lose generally if he fails active surveillance and if he develops metastasis or gets lost to follow-up because he's so young. In an individual like that, we have a protocol here at Duke where we're incorporating MRI along with a more intensive biopsy like that, and we would in general offer that to the younger patient. Now, on the other hand, in these more older patients, men in their late 60s and 70s, I'm not certain it's necessary to put them through that detailed of a biopsy. So we individualize. And we also have to take into account for the listeners, you know, a biopsy is not a completely benign procedure. You know, as Dr. Schaefer is part of this program today, and he's a world's expert on the increasing risk of biopsy-associated sepsis. And he talked earlier today about, you know, doing rectal swabs to do bacteria counts and sensitivities. And so more, you know, biopsies do harm people. And so you have to take a balanced approach. There's some men who want to take an active surveillance approach without having to go through that extra third biopsy or under anesthesia. So I think it's important just to talk to the patient.
So what would be your standard approach to active surveillance? Knowing that this is an evolving concept, so how would you approach this particular man if he came into you for an active surveillance protocol?
So I would, number one, I'm hoping he's clinical T1C with a non-palpable lesion. I hope he has ideally only 1 to 2 cores involved with Gleason 6. So 2 or less cores with Gleason 6, non-palpable disease, and we certainly would ideally want to see his PSA less than 10 to make sure he fits the ideal candidate for active surveillance in a younger individual. Then we would talk to him about the option of simply doing active surveillance with visits every 4 to 6 months, just with a digital rectal exam and a PSA during the first year, or I would talk to him about the pros and cons of almost an immediate remapping biopsy. Also recognizing that sometimes those mapping biopsies might cause erectile dysfunction. I mean, you know, you're putting a lot of biopsy needles in the prostate. I think there's unknowns to that. And so patients have to be counseled, and I'm not certain that every patient needs to have that intensive extra biopsy, especially if they're not going to get, as long as they're going to be compulsive about their follow-ups. Then if he's a younger man, if he didn't choose that first biopsy, we would probably recommend that he have another standard biopsy at 12 to 24 months, depending on his individual wants, needs, and desires.
How about PCA3? Have you incorporated that in any way into the active surveillance protocols that you follow?
Great question, and the simple answer is I'm not sure I know how. I mean, I've been using PCA3, and again, for the learners today, PCA3 just recently got FDA approved. It's a molecular urine test that we do after an attentive digital rectal exam. Basically, you do a prostate massage and ask the gentleman to give a urine sample soon after that prostate massage, and we're looking for a messenger RNA product in the urine where if it's present it shows a greater risk of prostate cancer. And we typically use it in our practice for the guy who's been through a couple biopsies and we can't decide if we want to do another biopsy or just follow him. personally, I have not used it to monitor active surveillance. Do you have any experience?
I would say like you said, we're trying to find our way with it. We are using it more, and much to my disappointment, very often men have an uninterpretable test. They don't have enough cells in their urine to really make a determination. But we are trying to use it, and I think it may have utility, but we have to figure out the optimum schema to follow. But I think it's it's the way that we're going to be going for a lot of these men in the future. A question from one of our participants, they were very interested in the fact that so many of your patients that come into your multidisciplinary center chose radical prostatectomy over the other modalities. Would you comment on that and give some perspective on why so many men chose radical prostatectomy when they came into your center?
So again, it was about 51% of those 700 patients who went through the multidisciplinary clinic. I honestly am not sure. Again, these men were educated by the urologist, who's the surgeon. They were educated by the radiation oncologist, and they were educated by the medical oncologist. A third of those patients were high-risk patients, and so many of those patients may have surgery, but we incorporated surgery in the context of multi-D, meaning I didn't say to that guy, I'm going to do a radical prostatectomy because I know I can cure you. I may have said to that high-risk patient, yes, we're going to start with surgery, but I fully expect you to need radiation therapy to follow, and I fully expect you may need my medical oncology partners to do protocol or non-protocol therapy after that. And so it's important to say we're not trying to pit surgery against radiation. We're just saying that, again, in the context of this multi-D, 51% of the patients had surgery. Interestingly, if you compare that to many unselected urology clinics, let's say you went to a mega urology group, the sense is that radical prostatectomy rates may even be higher and radiotherapy rates may even be lower. So again, do you have a sense in your multidisciplinary clinic at Jefferson what your rates of surgery versus radiation were?
Again, we found the same thing, that slightly more men chose surgery when they came into the multidisciplinary clinic, and much like you, we found actually a higher number, probably due to the fact that the Northeast Philadelphia area is much more compact and the traveling distance is not great. We found almost 90% of our patients who came into our multidisciplinary clinic actually stayed for their care at the Kimmel Cancer Center at Jefferson. But I think a lot of it just has to do with the geography, that it's much easier for people probably to commute in the Northeast than it is down in beautiful North Carolina.
Well, quite frankly, we were a little bit surprised that it was 58%. We assumed that a higher proportion of patients would have stayed here for treatment, but the problem is there aren't that many studies out there. Our hospital administrators, quite frankly, said, well, they were trying to find out if we were good, bad, or in the middle. And that's why, again, for the listeners, we would love for other centers to duplicate our results. I'd love to see further publications coming out to compare, because like I said, at Jefferson it was 90%, at our place it was about 60%, and then the selection, even in a multidisciplinary clinic, there's going to be some biases. I mean, there may be a patient there who bonds more with me than he does with the radiation oncologist, and vice versa. And so it was what it was. It was about 52% of the guys had surgery, and whoever is listening in, I'm not sure if they think that's too high or too low or just about right.
A question about nurse navigator came in from one of our participants. How do you have a nurse navigator, and what is his or her role in the whole multidisciplinary experience? It's
a great question. Ideally, for people listening in today who may want to go back to your center and set this up, ideally having a nurse navigator or a nurse manager is the ideal situation. What we have is a new patient navigator who is not actually a nurse, but she's a college graduate and is very experienced with working with patients who are newly diagnosed to get them either into the true multi-D or to see a surgeon, radiation oncologist, and negotiate help the patient negotiate the process. Once they're in the center, our program does have more than 3 registered nurses who are devoted to the program, the prostate program, and who are all trained, fairly intensively trained on counseling patients with prostate cancer.
So another question from one of our online participants is the topic of cryotherapy or other thermal ablation of the prostate. Would you comment on that in your multidisciplinary approach? Do you offer that to your patients in any way?
Yes, we do. Duke is also trying to push the envelope, if you will, on cryotherapy. Cryotherapy is an FDA-approved treatment for localized prostate cancer. As we know, it's been around for at least 30 or 40 years. The current cryotherapy equipment is a 4th or 5th generation with very small needles. And one of my partners, Tom Palasic, is a world's authority on cryotherapy. We offer full gland cryotherapy, and we offer focal cryotherapy under an investigational protocol.
So it's certainly a growing
Yeah.
option for many patients. Would you comment a little bit on what you think is going to be happening in prostate cancer in the next 3 to 5 years? What's your crystal ball tell you about the direction that we're going to be taking in prostate cancer?
So, great question, and certainly I'm not sure if I know the answer, but I'll give a stab at it. I do not think that the PSA test will go away. I do think that despite the U.S. Preventative Task Service draft recommendation of a D, I really don't think that I would hate to see us abandon PSA. It's not perfect, but no question it's better than anything else we've ever had as any cancer marker. So I don't see PSA going away, although I do see a trend perhaps to some patients getting the mixed signals, and we could see a shift upward in advanced disease as more patients fall through the cracks. And then hopefully over the next 2 or 3 years, we'll learn better to sequence these agents that we talked about today.
Great. Well, Judd, I have to tell you, it's been a great session down here at Duke, and we compliment you on all the great work that you've done all these years in prostate cancer. And this has been a very informative presentation, and I apologize to all those online participants that we were not able to get to and answer their questions, but hopefully there'll be other formats in the future. We'd like to thank the following companies for their support of this program: Abbott Laboratories, Bayer Health Pharmaceuticals, Ferring Pharmaceuticals, Janssen Biotech, and Teva Pharmaceuticals. Please remember to, if you're an online participant, to complete your quiz at the end of the session to secure your CME credits. My name is Dr. Leonard Gamella, and I wish you a good afternoon.
Thank you.